I really believe from experience, no one should suffer from swollen joints, swollen limbs for longer than like 48 hours, really, post injury. It is so common, though, to have athletes come to you weeks, days, weeks, even months sometimes after an injury like an ankle sprain and still have swelling. What does that mean? It means there's something going on systemically that's preventing normal blood flow and normal lymphatic flow from accessing the area. And so that is exactly what the protocol does. The MovementREV swelling reduction protocol is what I call it, is from years of, using different strategies to help athletes after injuries. I started learning with the Burrell Institute more visceral manipulation techniques, and I learned the value of checking distal pulses, especially from an ankle sprain standpoint. Posterior tibialis pulse would almost not be there, right? Like it was so diminished that I couldn't even feel it on palpation. And then what we learn in the Burrell Institute, that oftentimes when the posterior tibialis pulse is diminished, the problem is actually at the anterior hip. So I would do some work around the anterior hip and then recheck the pulse, and the pulse was better. And then also the swelling started to go down already within the treatment session. And then I was noticing with a few of my patients who had chronic swelling in their ankles or chronic swelling in their knees, oftentimes their locator tests, right, like the LTAP, directed me to their liver. And when I treated their liver, same thing. Their posterior tibialis pulse would be restored and the swelling would already start leaving. So then I started combining all the things that I knew worked really well. I would treat the thoracic duct area. So the left thoracic duct drains the lymph from almost the entire body, like 75% of the body. So the left upper extremity, 3/4 of the trunk, all of the trunk except for the right upper quarter. And then the pelvis and both lower extremities are all drained by the left thoracic duct. Whereas the right side veins and lymphatic structures drain the right upper extremity, the right upper chest, and the right side of the head. So I missaid, the left side of the head is drained by the left thoracic duct as well. So I did some techniques to make sure that this area of the left thoracic duct was mobile, was open. There was no possible entrapments going on in the scalenes or the clavicular pectoral fascia, the mid-cervical fascia of the neck, the subclavius muscle. That's like a big muscle that sometimes creates entrapment of the neurovascular structures in that area and decreases the space of the retroclavicular space, so the space behind the clavicle at the thoracic inlet. So working on that is really important. The other area that I started doing treatment is around the liver. So the liver is interesting. One, it's an organ that is related to our fluid function, but also the liver and the diaphragm make a joint with each other. So the function of the diaphragm is very dependent on a liver that is moving well. The liver actually, when it's moving, the liver rotates around an axis that the axis is the vena cava, the abdominal aorta, and the cisterna chyli, which is one of the main drainage spots for the lymphatic system. Mobilizing the liver helps to free up that important neurolymphatic vascular area there, as well as improve function of the diaphragm. And that three-dimensional breath is really important for the pumping of the lymphatics from that cisterna chyli to the venous system, promoting improved flow to the azygous veins, and the zygous veins also are an important part of the venous and lymphatic system too. So then the other parts of this protocol too is that anterior hip. So the area of the anterior hip, specifically underneath the inguinal ligament, ensuring that the space under the inguinal ligament allows for good free mobility of the neurovascular and lymphatic structures at the front of the hip. The femoral artery, nerve, and vein, and then lymphatics right there, right? Another area is the other end of the adductor canal. So the other end of the adductor canal is called the adductor hiatus. It's about four fingers above the medial knee joint on the inside, the medial side of your thigh. That is another great access point to free up and make sure things, the neurovascular and lymphatic structures, are free to flow. And then the lower leg, because it's sort of like, because of gravity, where lymph and fluid tend to always get congested, it's also a very powerful pump. We need the muscular pumping action to help the pumping of the lymphatics out of that area, as well as the blood flow to and from that area, right? So even when it's not like an ankle sprain that we're talking about, even when it's the knee, doing deep tissue and doing work to decrease swelling in the low leg is really important, because it is just, I think of the lower extremity, the lower legs, being like these really powerful pumps for the lymphatic system, as powerful as the diaphragm is. I think many of you may know that the diaphragm is a powerful pump for the lymphatic system, but not appreciate that the lower leg compartments, the lower leg function, is also a very powerful pump. So instead of relying just on compression, we're freeing all the neurovascular structures so the fluid is free to flow. You know it is flowing freely when distal pulses are restored, which brings me to the topic of what is normal pulse. That is tough. It's tough to know what someone's normal pulse quality is if you've never felt it before. So I tend to feel the pulses on all of my athletes. I have a very good idea of what their normal quality of their pulse is. Some people's pulse are very faint, some are very loud. It depends on a lot of things. But you will know, because sometimes the pulse when something is entrapped or congested will be diminished, but sometimes when vascular structure is entrapped, the pulse will be louder. In fact, that is exactly how we test someone's pulse, right? When we feel the radial pulse, we're pushing the artery into the bone. We're sort of clamping it down, and this makes the reverberation of the pulse rate to be more palpable in our hands. I don't know on someone if a really loud or a really diminished pulse is abnormal. All I'm looking for is a change in pulse. So if somebody comes to me post ankle sprain and I don't feel their pulse at all, I'm trying to restore it. If their pulse is really loud or different than the other side, I'm just staying curious to see what happens after treatment, both with their pulse and then also with the swelling in the area. What you'll notice is the swelling will start to leave, and which is almost like you blink your eye and then you look again and it's like, holy cow, I just looked here and your ankle was swollen and now it's not swollen at all. And then recheck the pulse, because now you're going to have a better idea of what is normal for them. And then that will be your target to what you're trying to get for every treatment. This swelling program, I love sharing it. I love talking about it because it works so well for acute injuries, for chronic injuries, for people with just general lymphatic congestion, and also for helping with healing of things that have a hard time healing, like those non-union fractures, like tendonitis type things that already don't get great blood flow, meniscus tears, things like that. So important to restore good optimal blood flow, fluid flow throughout the body. So hopefully this was helpful and gave you some strategies that you can use in your clinic or in your athletic training room and with your athletes, clients, or even on yourself. Thank you for joining me. We'll see you next time.